It's my pleasure to introduce Dr. Vera Tarman. She serves as the Medical Director of Renaissance, one of Ontario's largest and long-standing addiction treatment centers. She's a senior staff physician at Salvation Army and author of the book, Food Junkies: Recovery from Food Addiction. Dr. Tarman is also one of the co-hosts of the Food Junkies podcast and regularly advocates and educates on the clinical syndrome of food addiction. Welcome, Vera.
Thank you, Chrissy. Can everybody hear me okay? Yes. Okay, good. Before I start, I've been asked, Collaboration for Kids, if you got this flyer, it is a preventative health measure because although we're speaking to you, we need to be speaking to the kids. Let's make quitting sugar sexy. Let's make it attractive. That's what they're trying to do. Okay. So far what we've heard today is a talk on the addictive nature of foods. Michael Moss and oh my gosh, I'm going to forget names. Our two previous speakers were amazing in explaining the actual what the food industry does to make foods addictive. And then, of course, Robert Lustig talked very eloquently about what happens to the body when a person is being introduced to these foods. What I want to talk about is the next step, which is what is the line between addictive eating and food addiction, the syndrome? Why is it that some people can recreationally use and get away with it and moderate, for example, and others can't? They just can't. They have one, and one is too many, and 1,000 is not enough. There's something that happens. I'm going to use the addiction model, the George Koob's allostatic model of addiction, and focus on a term that he came up with himself called hypercataphia, as being that point from where addictiveness becomes addiction, and then essentially where moderation might work and abstinence is now, moderation might work here, but at this point it doesn't work anymore and abstinence becomes critical. Whoops, okay, so I always have to have my dog in there. So this is really a talk on the essentiality of abstinence. And in a talk where we are discussing the consensus of food addiction, what is food addiction, I think we also have to come to a consensus about the importance of abstinence. When is it really important? When can you get around it somehow? We need to have some discussion about that, and I'm going to make sure it happens today to talk about the A word, the abstinence word. Now, what we've heard so far today is this is setting the groundwork, that there are various drives to eat. And we can look at the homeostatic model, which is what Dr. Lustig talked about, the ghrelin and the leptin irregularities that the processed food industry does. And then, of course, insulin, where when a person has insulin resistance, which happens with a lot of processed food, where insulin should be a satiety hormone, it actually doesn't because it's resistant. And now we're at the whims of hypoglycemia. You have so much sugar, you go up, then you crash, you go up and you crash. And you essentially have a syndrome of eating that looks like food addiction, craving and insatiable appetite, where in fact you may not actually be a food addict per se, but I actually think it's the beginning stages. It could be an overload of a dual play, or it could be one large syndrome. And then we have the hedonic model, which is the neurochemistry, and that's primarily looking at dopamine. Of course, there's eating disorders too, which we have to sort out where that all fits. I actually think that at some point we are going to come to some consensus about that it is actually part of this picture too, but we're still working on that. Okay. So it's not going. What do I do? Oh, now it went too much. All right, sorry, go back. I see, I just have to be patient. This is the universe telling me, slow down, Vera. But it doesn't know I only have 25 minutes. Okay, so what I want to get to is the next slide. Just be patient again. Anyway, yes, this slide. So we've already looked at these things. And why it's important to know about the hedonic model and the homeostatic model and the hedonic model, what I like to say the hormonal model and the neurochemical model, is that it actually shows how this phenomena develops from addictiveness to addiction, and that it is actually a gradual, we call addiction a gradual chronic progressive condition, and that these two overlays work together into a chronic progressive pattern that we ultimately call addiction. And I'm going to use a term called borrowed from the addiction field. That's the allostatic model of addiction. I'm just going to jump ahead here. I have all my slides in case there's questions, but we don't want to get to these. But this isn't going to work if it's, come on. All right, well, okay. This is not bad. Okay, so when we talk about addiction, we're looking at, with addiction, we're interested in the hedonic model. And in that hedonic model, we talk about dopamine, endorphins, serotonin, and endocannabinoids. I'm going to focus mainly on dopamine because that is really the main, it's the mother, the father, the matriarch, patriarch understanding of addiction. If you get the dopamine piece, you've got quite a bit of it. And then we look here at this slide here, the nucleus accumbens. Can I actually show a thing here? Yeah, right here. That's where the hedonic piece works. But importantly, we have the amygdala here, and this is actually where you see when you see both of these engaged together, that's where you start to see addictiveness to addiction. So we're going to focus mainly on dopamine, and this is my favorite slide of all. We've been talking about the surplus of dopamine, but let's look at what I mean by the surplus, or what we mean when we talk about the surplus. So this is a diagram that was made, well, I made it, but it's based on a study that was done sometime in the 2000s, and it was basically done on rats, and the units don't matter so much, but the comparisons are really interesting. And they found that, if we want to consider dopamine, which is a natural motivating neurochemical that we all have, that we need that we have sort of a currency, a general daily currency of 100. And I get 150 or even up to 200 to motivate me to do the extra work that I have to do. That's the way it works. That's the joys of life and sometimes the boredoms of life when the dopamine is low. But we live in that realm for the most part. And in the food addiction world, we would call that food sobriety, food serenity. You want to be extra excited and you want to have a bit of lows. It's just generally that's life. And then we are granted, either through God or the universe or nature or evolution, whatever you want to call it, we've been granted the ability to move into larger than 200, which we would call the supernatural versus the natural. And everybody has, quote, well, maybe not everybody, but most of us have had 1 or 2 or 3 or 4 or 5. Abraham Maslow calls them peak experiences. He says no more than 5 in a life. Now, when I ask my addict patients, how many of these do you think you should have in a lifetime? 1,000, 10,000. But no, you're granted the ability to move into this realm of the superfluous, the extraordinary, the abnormal, a few times in a lifetime, and without a cost. But what happens with addiction is you get to live in that realm. It's basically spirituality on demand. And the person that likes this will, of course, want to do this more than 4 or 5 times in a lifetime. Why not 4 or 5 times in a week? And that would be fine, except that we have a homeostatic mechanism built in. It's part of the general premise of life. We're taught that in medical school 101, that we have some sort of universal laws, and one of them is homeostasis. And so the brain is going to say, Vera, you've had your 4 or 5 of a life in this week. That's enough, and it's going to pull back. Really, too much of a good thing is dangerous for us. And so essentially what happens, which we all know, the downregulation of the dopamine receptors in an attempt to correct that. And so that's sort of the premise of that. Now, George Koobs wrote about what happens in this larger picture of addiction. He said, if you look at the very top, up here, this might be the dopamine going up to 100 or 150, and then you're going to go down, that's okay, and then you go back up again. That's just life. It's the ups and downs of life. It's good. And we have usually a set point, a general set point that is my level of general well-being. But in the addiction model where you have, so if we look here, where you're using a substance and you're getting too much of a good thing, the body compensates. And I really like to say, this is a normal response to an abnormal environment. So when you're in that abnormal environment, the body will compensate and start to reduce the receptors, and so that you ultimately have a decreased set point. Now, the body is going to try to regulate that up, but they can't because you've got a decreased amount of receptors. So there's a general, gradual, the sort of even set point is dropping over time into a sort of generalized dysphoria. Just generally, I don't like how I feel. And then I don't like how I feel, I'm going to want to correct that. Not because I want the pleasure of going up, but because I don't want the pleasure of being down too low. And in the language of operant conditioning, we call the first one a positive reinforcement. I use because it feels good, and then eventually the feeling good doesn't, I mean, where is the feeling good here? It was up here, and here it's getting, I don't really get much effect anymore, and now I'm using just so that I don't feel bad. So that's positive reinforcement, negative reinforcement. And where is that line when a person has gone from a little bit of positive to virtually nothing and only negative? George Koobs calls that the hypercataphia. And, gotta slow down. Not George, sorry. Dopamine Nation, help me, who wrote that? Anna Lemke, thank you. Yeah, oh, is she, great. So she talks wonderfully about the negative reinforcement and its pull in addiction. And I think that that's actually the point at which something becomes addictive to addiction. And that's really what I want to talk about. So that's the allostatic model. And then we move to, this is a nice diagram that he drew. And just to show you here, this is the excessive use. Like you can see, like there's not much positive happening here, and there's a lot of negative, but the general set point very low. So you're constantly driven to feel better. And he included in this, which we also know, that we have genetics. You can come to the plate, as it were, the stage, the scene, with already a genetic predisposition. Maybe your dopamine receptors are already not so hardy. Adverse childhood experiences, that there's been some dysregulation from your set point because of that. And then you've got psychiatric comorbidities. Just add to the list, and you're continually bringing this down so that there's basically, it's all about negative reinforcement. In other words, I'm using just so that I don't, thank you, perfect, I don't feel bad. Okay, I like this slide. In terms of that, remember I showed you that diagram of the dopamine, like 100, 200, 300, 400. Carolyn, oh my gosh, Davis, actually in Toronto, Canada, wrote a number of years ago about her eating disorder patients when she saw there's something about them that is behaving addictively, and she looked at this dopamine surplus, and she said there's a neuroadaptation, which we now call tolerance, that develops, and essentially we start to see stages of food addiction. And I actually thought that, okay, using that thinking, and then we're using our general concept of addiction, where we recognize substance use, substance misuse, which might be recreational thinking, still using, still being able to moderate. You're still getting a positive effect. But over to here, where now you're using because you have to, and it's almost like it's a different animal here. And then ultimately addiction, which is, that's running the show, regardless of the food. People are using just because they have to. They don't even care what they're eating. Somebody asked earlier, what about healthy foods? Yeah, I'll take whatever you got. Like it's not about, it is about the food, but it's not about the food anymore. It's also about the individual and what's happened. And when you reach that point, you fulfill all the criteria of addiction, which I'm not going to get into because we know them. Another picture of my dog. And the basic stages of food addiction. So I wrote this article that said, let's call this stages of food addiction. Don't want to dwell on that. What I want to dwell on is the point of that article was to say that means different treatments for different stages, different levels of the progression. Like if you're at the positive reinforcement, moderation may work very well because you're still enjoying the food and you're not yet compelled to use the food. So maybe you can. Like if you're at that stage, go for it if you can. But if you're at this stage where it becomes actually impossible to do that, then abstinence becomes critical. So I've got my 2 words, abstinence, there in the later stages, which are essentially the stages of positive to negative reinforcement. This term, hypercataphia, which Koobs made to say that it's that particular syndrome where negative emotions drive the addictive process. And how that happens is, well, actually, I'm just going to go ahead. There's basically 3 mechanisms. There's the downregulation, the tolerance that's already been talked about very eloquently. There's also, when you have the downregulation, so the person that's struggling with addiction recognizes, I need more to get the same effect. Whatever is left there that has not yet been downregulated seems to become more sensitive. It's almost like there's a homeostatic mechanism there too, an attempt to correct, because I'm not getting as much, so can I push the envelope with what I've got left? So you have a hypersensitivity of what's left, plus you have the stress response, the corticotropin releasing factor, which is part of the a stress response that promotes cortisol and adrenaline. That gets higher too, so that negative response, the negative reinforcement, is not just I need to use so that I don't feel bad, but I feel really bad, like I'm stressful. Like we could call that withdrawal, we could just call that stress, we could just call that insatiable cravings. So we've got 3 different dynamics that are feeding this negative, this secondary, this hypercataphia. I'm just going to jump ahead. And the hypercataphia, it gets worse with repeated use, which makes sense. If I'm continually using more downregulation happens, more stress response. So this is a chronic progressive disease. It's not that it happens and that's the end of it. It happens worse and worse and worse and worse, which makes sense. So using will make that worse. What's very interesting and drives the addiction from mid to end stage. What's, I think, also really interesting, well, this is also talking about the frontal lobe and memory, which also gets affected. We can talk about that in a question if we have to. Now, somebody asked in the questions, 10 minutes, okay. Somebody asked in the questions, is there a psychological component? So I'm talking about the physiological here. So yes, there's the downregulation of receptors, there's the upregulation of the stress receptors, but there's also the psychology. When I am feeling really bad and I take my substance and it relieves, that's a operant conditioning. That's a powerful pairing. And if I'm feeling really bad, it's an even more powerful pairing. And if I'm feeling really bad, it's like the more I use and it gets worse, the more powerful that pairing becomes. So there's a psychological piece, so that even when I stop, I'm still lumbered with that memory. I see this and I know I feel better. And that's the psychology, and that's why we have addiction treatment, which is all about the psychology. People, places, things, cues, relapse management. The food's not even in you anymore, but even a year later, you still have to deal with that memory, the psychological cues, which is why this is more than just a biological disease. Okay, so I want to just get to here. So this is a really nice diagram that Koobs did, where here's the positive reinforcement. This is chronicity from maybe just having a few of those Doritos or whatever it was, but you can't have just one. You know, you struggle a little bit, okay, but you get over to here, you don't even care if it's the Doritos or it's the, who cares, it's carrots, I don't care. I just want to eat as much as I can because I'm trying to relieve this. Now, look at here. You're going to have withdrawal, and then even in abstinence, it's continuing on because you're suffering the withdrawal here, you're abstinent, and then if you use, like I said, you've just repeated the pairing. And if you use again, you repeat the pairing. If you don't use for a while and the cravings go up and up and up, unless they extinguish, you have, even in prolonged abstinence, a repeated pairing. One thing we know is that if I want to train the dog to jump, I don't have to feed them every time they do the jump. I just have to do it once in a while, especially when they really want it. Like it can be even indeterminate. Like the psychology of this actually takes over in some level. So we have this. Now, if a person is trying to they're trying to quit because they say, okay, I got to be abstinent, and they can't be abstinent, and they relapse, then essentially you've cued another loop like this. If you stay, let's say you're not calling it I'm quitting, you're calling it I'm going to do moderation. It's still a repeated stop and start, stop and start. And if you've reached past this level, you're just continually fueling this thing so that even in abstinence, if you relapse or use again later, a year later, unless the cues have desensitized, you're just strengthening the connection. If you get, I hope I've made my point there. So abstinence is really important. There's another body of literature that is a parallel body of literature, which is really interesting. It's kindling literature. How am I doing for time? Okay. The kindling body of literature is interesting because it talks about alcohol and seizures. And most doctors know you don't want the patient to have a seizure because that means they're at risk for having another seizure. The seizure threshold drops. And the people in the kindling work said, maybe it's not just seizures, maybe it's cravings, maybe it's vulnerability to relapse. Each time you have a relapse, you're more vulnerable to another one. And kindling, it's like you put a log on the flame, that's one relapse, then another log, then another log, and then another log, and then basically you got a bunch of logs, and the last thing you want to do is have a flame, because it's there, ready to go. And if you are a non-user, those logs haven't been laid down, no problem. But what we're saying is at this particular point, when it goes all the way with the repeated pairings, multiple logs, what we're looking at is a condition. I gotta slow down. What we're saying is a condition that is I hate to say this, but not curable. This is a condition that's here, that's set, and it can be in remission. So I can say, hi, I'm Vera, I'm a food addict in remission. I could say I'm in recovery, but in remission, knowing that if I were to have a little bit of something, again, 1 is too many and 1,000 is not enough, I put the flame to that fire of the kindling. So it is a disease in remission at this point, when we get to that negative, the hypercatapheic point. So I want to conclude here by saying that abstinence at a particular time may not be the only tool you use, it may not be the first tool you use, but at a particular point, abstinence becomes an essential part of recovery, of health, of happy, joyous, and free recovery. And as a, thank you, as a call for research, we have a scale, the Yale Food Addiction Inventory, which tells us, is this person a food addict? Maybe they have an eating disorder, whatever they got. Could we have another scale, a hypercatapheic scale? Is this a person where we should not promote moderation, where we should really encourage, look, if you continue to use this substance, things get worse because it's a chronic progressive condition, even into sobriety. So could we have a scale that actually shows that? So that's really what I wanted to say, make the play for, or the call for abstinence at a particular stage, at a later stage of food addiction, and that it's based on the hypercatapheic model, and that more research could be done on that. And that's it. Thank you. That's running a marathon.
Hi, Dr. Vera.
Hi.
I so respect your work. Thank you so much for all you bring to the field. Right here.
Yes, thank you.
I just wanted to ask, I know that you've signed the consensus statement, or you've endorsed it, right? That we all put together.
Yes.
And I have as well.
Yes.
And I know that you and I both are in agreement that for someone in recovery in an abstinence-based model, abstinence from ultra-processed foods only is not going to be sufficient to ensure their recovery.
Yes.
And yet, we're very much endorsing this this path forward for ultra-processed food addiction being the label. And I was just wondering if you could speak to your reason for endorsing that.
Yes, okay. I am a very expedient, prudent person. I'm a very practical person. And we've tried our damnedest, pardon me, to get food addiction across, and people are so abhorrent to that word. So but thanks to Chris Van Tulleken's work and Michael Moss and people like that, we're not, using the word hyperprocessed food is more palatable than addiction. So my thought is, let's get in there, and then we can start pushing our own agenda to expand it. Because I really think that ultra-processed food is the gateway. That's a perfect terminology. But that when the progression continues, if you recall, I said, it can be carrots, it can be too much celery, it can be just volume, it can be many things. Like food addiction is not just hyper-processed food, but that is often a start. So is this the word expedient? I am practical. I'm going to go judicious.
Thank you.
I'm just going to go with what works. Yeah.
Thanks.
It's a political.
Hello.
Yes.
Hi. Yeah,
Okay.
I'm right at the back. I wave a lot.
Left or right?
You're
Okay,
right.
all right, yes, okay,
Hello.
yeah.
First of all, please give my regards to your dog.
Thank you. See, isn't she cute?
She's amazing.
She's made me a nice person. I wasn't so nice before.
I identify. I had my own version of that. I'm abstinent one day at a time from compulsive overeating, and I know what that means for me. What is abstinence? 'Cause you're talking about abstinence. I was just wondering what your definition of abstinence is.
Beautiful. That's why I like this model, this Koob's model, because it doesn't define. It talks about anything. Like Robert Lustig said earlier, it could be gambling, it could be whatever. It's just addiction. And so what defines abstinence is just whatever is driving the compulsion. And that can be like volume, for example. It can be just eating. So that concept of eating addiction, sure, I'll go with that. It can be restricting. I'll go with that too. People are like, wow, I've lost some weight. I want to lose more. I mean, it can be anything. And at a certain point, because we're talking about dopamine, many roads lead to Rome. Rome is dopamine. And the multiple ways to get there, yeah, that's why I think addiction is a much better, broader term. And abstinence then is, basically, it is specific to the individual, but almost universally, it's ultra-processed food and sugar first. But then it's specific. That's why we need individual coaches to speak to each person about their level of abstinence. And somebody else mentioned, I think it was Robert Lustig, that things can change over the course of a lifetime, easily. You know. Okay, is there, yep. Oh, sorry, it's not me that asks.
Do you think that someone can do it with abstinence alone, or do you think there's always a need for kind of additional psychology support and yeah, group
You mean,
support?
do you think it can be just the food?
Just the food,
Or just
yeah.
alone? Because that's kind of two different questions. I think the food is number one. It's the essential. It's a bit like post-traumatic stress work. You don't really want to do the work necessarily when the person walks in. You might want to spend the first 6 months to develop a relationship and all that kind of stuff. But ultimately, the work doesn't begin until you put the substance down. But that's only number one. And in the 12-step program, that's the first 3 steps, and there's another 9 to go. Because what you're trying to do now is you've got that euphoric recall, that psychological pairing that is very powerful. In fact, it's powerful like post-traumatic stress. One event affected me even to this day. We could call this post-traumatic euphoric recall. I had that one connection. I don't need many more, and I'm going to remember that. And that's now, I'm lumbered with that knowledge. And so I have to now learn how to live with that knowledge so that that doesn't suck me back into using. Because that's what happens. We have intrusive thoughts. We wake up in dreams. We have all sorts of things, the same as post-traumatic stress when a person is in addiction. And we need to have tools to work with that as well as the food. And even though you didn't ask about the social piece, can I do this alone? We understand in addiction, the willpower is hijacked. And so my common sense is hijacked. And so of course, I always think of it as like you're playing chess with somebody. You're playing chess with yourself. And yourself, I'm not going to win against the part of me that's more motivated than me. That's the addict within. I need to have the help of somebody else who says, no, 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 no. If you do that, you're going to get caught and you're going to lose your queen or something like that. Don't do that, because I won't see that. It's been hijacked by the addiction.
Hi, Doctor.
Yes.
Thank you for all your work, actually. You inspired us a lot over the years. My question is, as you just mentioned, the repetitive use of sugar, ultra-refined processed food, or whatever it is altering your reward system, and basically your dopamine receptors are desensitized. Under abstinence,
Yes.
is that reversible?
That's a really good question. Is it reversible? In general addiction, everybody in treatment hopes that it is, and that 2 or 3 or 4 or 5 years later, they hope that they can moderate again. It's been my experience that happens on occasion, but more times it doesn't happen. And I think that kindling language is very useful. It's almost, I guess, like maybe the endocrinologist can tell me, once you're a diabetic, once you've been insulin sensitive, resistant, now you're eating well and your sugars are good. But if you go back into the bad food environment, don't you become diabetic really quickly again? Like it's almost like it's latent. And I think the same thing happens with, it's like insulin resistance, dopamine resistance. It's latent. And I like the kindling analogy because it's all there. It's quiet because there's no fire. But as soon as the flame, it's back. And there was some research on incubation of cravings, that cravings can actually incubate. Now, they were saying 3 to 6 months, maybe a year. I don't know, maybe it's longer. That just depends on the research. They have to ask that question. So usually when a patient asks me, can I try again? I would say, are you willing to take that chance? Because if you go out again, you might not come back. And if you are willing to take that chance, why? That's making me suspicious. Is your addict mind now hijacking your reason of whatever? I know it's a bit of a tautologic argument, but I would wonder that. That's why we want to have sponsors or therapists or coaches. If you say, I want to try this again. Okay, why? What is it about that? Yeah, okay.
Hi, Vera. This is Tosca over here on the side. I'm standing up. I'm very tall.
Oh, yes, I see you.
Nice to meet you in person. I've talked to you so many times. I have kind of a question. I like that you said you're practical. I was thinking
pragmatic. That was the word I wanted.
Pragmatic.
Yes. Pragmatic.
I also feel like I'm very pragmatic. And listening to us talking about like getting some legislation, I understand the definition of ultra-processed food and like what the goal of this is. And I was thinking of a story when COVID hit and everybody was like, oh, non-essential stuff is like, we're not doing it. We are only having the stores open. And they shut the liquor stores down and they shut down the marijuana dispensaries in Colorado. And that lasted for about, I don't know, 48 hours before people kicked up and were like, and so I just, you have experience, I'm with Shift and we're doing treatment with people and we know the power of these cravings in people's lives. What do you foresee happening if we do get some legislation put in? And I like Dr. Lustig said, we need laws and we need rehab. How can we, what's a practical way that we can, we've got a nation, a world full of addicts.
Yeah, this goes very nicely to collaboration for kids. We got to get the kids before they get hooked. That's the first piece. Let's not avoid the problem in the first place. And so thank you so much for your advocacy in that. It's so crucial. And then for the rest of the folks who are already there, don't forget, they're now going into withdrawal, and there's going to be a lot of pushback. So we need to have support. And it needs to be recognized as a truly miserable condition that people will do anything to treat themselves with food again. So the problem is we don't recognize it in larger society, but if we did, that's what I guess that's another thing that Robert Lustig said was we need to teach people more awareness so that when they are starting to feel some withdrawal or whatever it is, that it's a legitimate condition and they can actually seek, well, hopefully there will be help, but that it's a legitimate request to ask for help.
Vera, we have another question up here.
You had a question too.
Hello. Two questions. So, which one first? Go ahead.
I don't know. It's not my call.
All right. So I'm a physician from Poland. I came here with my twin brother. He is a physician as well. It was a master plan of our parents. So the question is, it's very popular rule in Poland is 80-20, which says that 20% of the diet should consist of so-called comfort food. Because if you don't do it, you will have a bad relation with the food.
Right.
So the question is, of course, the question, do you think that such recommendations with such recommendations you can overcome food addiction?
No.
And do you think that this principle may be a product of the food industry?
Yeah, this person is a product of the food industry. You just answered. The first part I want to say, we actually talked about this, Molly and Chrissy and I. Let's reframe the conversation. We've recognized that this is not a food, this is a food additive, this is a food poison. You wouldn't ask your kid, let's moderate you and have a cigarette once in a while. You just wouldn't do that. So if we say, okay, moderate good foods, you don't want to be eating strawberries all day. I mean, it's a lot of fructose, and you wouldn't, because you'd be on the toilet all the time. Like, nature naturally moderates us. So we can eat moderate foods if they're healthy foods. That's fine. Then that's where we take care of that sense of deprivation. Because when you're not eating that stuff, a watermelon is delicious. It's absolutely delicious. It's fine. I don't need anything else. When I'm eating something else, I want something more. I want something that has watermelon flavoring in the watermelon. That's the whole thing that processed food does. So if we reframe the argument to real foods, then I think moderation is possible, and addiction wouldn't be to the extent that it is today. But we're not living in that circumstance. So no, I don't think there's a 20% possibility for people who have crossed that line, that hypercataphilic line.
Vera, I'm going to challenge your model, and hopefully in a friendly way.
Okay.
You showed the allostatic load model, and I've heard that, and I've seen it many times.
Yes.
What do you think the role of cortisol is? I mean, you alluded to it, you mentioned it, but you didn't assign it any primacy. A colleague of mine in Paris and I have actually built a computational model of the limbic system.
Okay.
And cortisol is primary in this phenomenon, in part because it actually leads to neuronal cell death. And it is that cell death that actually takes you to addiction. And I was wondering where you think the cortisol story is, whether or not you can get from wanting to needing without stress.
That's a great segue. Wanting to needing, absolutely.
Well, that's Kent Berridge's.
Yeah.
Frame.
Yeah, because the wanting is all about the dopamine and the euphoric recall and all that stuff. And the stress response, I think, becomes primary on this level because there's no longer any pleasure. And whether it's primary, I don't know. I guess we'd have to look at the research, the specifics. My impression with the Koob's model is that this is diminishing, and then it is all about trying to reduce the negative affect, which is probably fueled by stress. Yeah, I think
I think stress is, sort of part two. The dopamine is part one.
Yes.
And the cortisol is part two. And you can't have addiction without both.
I think you're absolutely right. You're not challenging. I'm with you on that one. But I like that need, or what does it want to? I don't know. That's good.
Hello? Hello?
Yes, yes.
Vera, I love your work. Thank you so much. Thank you very, very much.
Thank you.
So I inhabit the world of type 2 diabetes, and in that, prevention is so much easier than waiting for somebody to have diabetes. So if somebody has pre-diabetes, I can sort that in 93% of cases.
Yeah.
If I wait till they have diabetes, it's harder. If I wait till they've had diabetes for 10 years, it's even harder. And listening to you today, I think the same applies to addiction.
Yes.
And it's been my experience that your first chance, the first go, is your best go. Could you say something about prevention? What should we do? Do you think specifically? What ideas have you to help young people? Because I have many patients by the age of 15,
yes,
they are rip-roaring addicts to energy drinks. What should we do?
I think that when I look at the problem of today, it's the fact that we don't acknowledge this as a condition, and that we don't acknowledge that food is a poison, or sugar is a poison. That's why I think your work is so important. So if we can reframe the conversation so that you won't get into trouble if you're walking into an environment that it's like if you're going to start using heroin that you're running a risk of becoming a heroin addict. But we don't know that in this context. So we have to have public awareness, like literally have chocolate bars with horrible pictures of something on them, just like we do with cigarettes, so that it's very clear that this is what this leads to. But I think that the main thing is the kids. Make it attractive. Make it actually easy to say when you're going to a party, you know what, I brought something else. I don't want that. I like this. And the other person goes, no problem. No problem. Whereas we have a subtle social pressure because of the food industries telling us that it's love and connection, blah, blah, blah. It makes it really hard to say no. If we made that easier, for example, you have to go outside to have a cigarette, you have to go outside to have a dessert. Wouldn't that be nice? Yeah. Are we good?
One short question. So, I'm a mother of 2 teenage children. And my children do eat fairly healthily, but it's very interesting what they come home and report from high school. And it's not just about the food problem. I think we've got a growing problem with teenagers in particular, vaping and technology use, whether it's video gaming or playing on phones or whatever. In fact, we got a message home from the school this week saying there's a new policy in Scotland on the use of mobile phones in schools because they're trying to tackle this issue a little bit. And I just wonder whether there's an issue about addictions, more than one addiction stacking up here to be a problem, and almost making the food issue seem less of a problem as a result, because the focus is perhaps on other areas, but also that it makes it even more difficult to tackle the food addiction when you have other addictions that perhaps are there too.
Yes, absolutely. I mean, it's a gateway drug. Cigarettes is a gateway drug. Yes. So we want to address it all. And I'm not sure if I'm answering your question, but I do want to say that along those lines, if I can just toot my horn, whatever it is, I did a couple of raps for teenagers, which are anti-sugar raps. We got to make it cool. We got to make it like, where's our person who sings? Where's our come over here. We got to make it cool. We got to make it like, for example, say no to sugar. Say no to sugar. Come on, come over here. Say no to sugar. Everybody, if you believe in it, say no to sugar. Say no to sugar. There you go. You got to make it cool, fun.
And Vera's wraps are being shown just outside on our table, on the first table on the left, if anybody wants to see.
It's not me singing. There is one real person singing, and then the others are AI induced. But they're pretty good. They're pretty good. Okay, thank you.